She's here already. Well, first up, I'm very pleased to introduce Hazel Booth. Hazel was the first nurse practitioner to be licensed in the Yukon. She has completed numerous educational courses in controlled substances prescribing, including Suboxone. She brings expertise as an experienced primary health care NP, and currently Hazel provides locum coverage for the Taiga Referred Care Clinic and clinical oversight for Yukon Government's COPD home health monitoring trial. Her talk today brings the primary health care lens to addiction. So please join me in welcoming Hazel.
Good morning. I have a presentation. There it is. Okay. I'd like to acknowledge our local First Nations people and their traditional areas and their elders. Thank you for having us here today. I'd like to start my talk today with a story. When I first graduated from nursing, I was fortunate to land a job in the neonatal intensive care unit at the Children's Hospital of Eastern Ontario. This was a time when nursing jobs were scarce and new grads were certainly not hired into a specialty area. Needless to say, there were many days I felt inept and overwhelmed. I had a beautiful nursing mentor who taught me things that serve me in my career today. I can still hear her reassuring me and telling me it's all okay. Don't get so stressed out about the complex pathophysiology that's going on. It's all about the ABCs: airway, breathing, and circulation. And now, later in my career, I've sat in the very privileged seat of understanding health with a much deeper and broader perspective. That wee baby who was born premature and in withdrawal is so much bigger than airway, breathing, and circulation. I've come to have a greater understanding for the power of addiction as a chronic disease and risky behaviors as actually responsive behaviors to the greater psychosocial stressors in life. And now today, as I provide locum coverage as a primary healthcare nurse practitioner at Taiga Referred Care Clinic, there's not a day that goes by when I come home from working there and I feel like my life is so simple. I feel the vulnerability, the reality of it could be me, it could be any one of us. Every patient has a story, and common themes include a system that has failed that person, and more often than not, a significant traumatic event somewhere in life. I've been asked to be the first presenter today, not because of my expertise in addiction, but to remind us as we go through the next 2 days to be conscious of how much effort we put into addressing the low-hanging, attractive fruit of whether to prescribe or not to prescribe or how to prescribe naloxone, methadone, Suboxone, but to be conscious of how much effort we put into creating a space in society where psychosocial stressors are less and protective factors from addiction are strengthened. So my objectives this morning are to review primary, secondary, and tertiary prevention, to talk about the psychosocial stressors in health and disease, and to reframe thinking about addiction to a chronic disease, and to revisit what it takes to have successful health outcomes. Many of you will likely have heard of the reference to putting an ambulance at the bottom of the cliff, or building a fence at the top. Well, as it turns out, these sayings come from a poem that was written in 1895. That's a long time ago, and it's a really old poem. I'd like to take the time to read it to you in full this morning, as I think it's well worth our time. As I read the poem, take a few minutes to reflect on where you work and what you do to influence the healthcare system at a systems level. Also, give some thought to the conversations that are happening in healthcare today. The Ambulance Down in the Valley by Joseph Malins. 'Twas a dangerous cliff, as they freely confessed, though to walk near its crest was so pleasant. But over its terrible edge there had slipped a duke, and full many a peasant. So the people said something would have to be done, but their projects did not at all tally. Some said, put a fence round the edge of the cliff, some, an ambulance down in the valley. But the cry for the ambulance carried the day, for it spread through the neighboring city. A fence may be useful or not, it's true, but each heart became full of pity for those who slipped over the dangerous cliff, and the dwellers in highway and alley gave pounds and gave pence not to put up a fence, but an ambulance down in the valley. For the cliff is all right if you're careful, they said, and if folks even slip and are dropping, it isn't the slipping that hurts them so much, there's the shock down below when they're stopping. So, day after day, as these mishaps occurred, quick forth would those rescuers sally to pick up the victims who fell on the cliff with their ambulance down in the valley. Then an old sage remarked, "It's a marvel to me that people give far more attention to repairing the results than stopping the cause. When they'd much better aim at prevention, let us stop at its source all this mischief," cried he. "Come, neighbors and friends, let us rally. If the cliff we will fence, we might almost dispense with the ambulance down in the valley." "Oh, he's a fanatic," the others rejoined. "Dispense with the ambulance? Never. He'd dispense with all charities, too, if he could. No, we'll support them forever." "Aren't we picking up folks just as fast as they fall? And shall this man dictate to us? Shall he? Why should people of sense stop to put up a fence while the ambulance works in the valley?" But the sensible few who are practical too will not bear with such nonsense much longer. They believe that prevention is better than cure, and their party will soon be the stronger. Encourage them then with your purse, voice, and pen, and while other philanthropists dally, they will scorn all pretense and put up a stout fence on the cliff that hangs over the valley. Better guide them well, the young, than reclaim them with old, for the voice of true wisdom is calling. To rescue the fallen is good, but 'tis best to prevent other people from falling. Better close up the source of temptation and crime than deliver from dungeon or valley. Better put a strong fence round the top of the cliff than an ambulance down in the valley. So that was 1895. I'd just like to see a show of hands. How many people feel we're making significant progress in our conversation? And as you work through the next few days, bear in mind the fence or the ambulance, or is it some combination thereof? So I recognize that there are some people in the audience today who work in healthcare, and this will be a review, but it's an important concept to understand. As a quick review, we presently think of healthcare as having 3 levels: primary, secondary, and tertiary. Primary prevention is all about preventing the health problem. It's before you get to the fence. It's things like immunizations, counseling about safety, and doing things that prevent injury or disease. It includes other determinants of health, such as social and physical environment, stress and healthy behaviors, environmental toxins and healthy relationships. Reducing or eliminating risk factors prevents the addiction from occurring in the first place. An example is general education to everyone around opioids. There is a call in the evidence for fine-grained education that makes distinctions among different classes of drugs of abuse and clearly delineates the psychological effects of opioids and underscoring their highly addictive qualities. There are people with addictions who talk about not having had any of the substantive knowledge of opioids or the addiction process prior to becoming dependent. Improving health literacy around addiction is an example of a primary prevention. Certainly, though, don't misunderstand this or take this out of context, for primary prevention is far greater than just educating our teenagers on the addictive process. As you will learn later in the presentation, we also need to be addressing the psychosocial stressors. Secondary prevention is about detecting disease when people don't necessarily have symptoms, or perhaps it's in its early stages and we're going to minimize the impact on the person. Examples of secondary prevention are things like getting your blood pressure checked in order to make sure you don't have high blood pressure, having mammography to screen for breast cancer, or a colonoscopy to look for bowel cancer. During a prenatal visit, the healthcare provider will ask questions to screen for substance use. We want to find the disease early so we can get early treatment. The third level of healthcare is tertiary, and tertiary prevention is minimizing the negative disease that's already occurring. Examples of tertiary prevention include therapy to minimize further target organ damage, or helping someone with addiction to prevent relapse, or these are also your harm reduction programs, or prescribing Suboxone. So let's have a look at this diagram. And I don't know why it's not color, but usually it is. Anyways, the bulk of healthcare is focused on the very medical, secondary, and tertiary prevention. Let's take a look at some of the determinants of health and the psychosocial determinants of health, because it's really, really important that we not only think about these, but think about how your role can influence these. It's actually these non-medical roles that can have our biggest impact on health outcomes. Think big, think non-medical, and think broader. The World Health Organization talks about the determinants of health. What are the determinants of health? They include many non-medical factors such as income, social position, access to healthcare, access to resources, physical environment, social cohesion, occupation, education, and environmental exposures. Higher income and social status are linked to better health. The greater the gap between the richest and poorer, the greater the difference in health. Low education levels are linked with poor health, more stress, and lower self-confidence. Safe water and clean air, healthy workplaces, safe houses, communities, and roads all contribute to good health. People in employment are healthier, particularly those who have more control over their working conditions. Our social support networks, greater support from families, friends, and communities is all linked to better health. Our culture, customs, and traditions, and the beliefs of families and communities all affect health. Genetics, inheritance plays a part in determining our lifespan, the healthiness, and the likelihood of developing certain diseases. Personal behaviors and coping skills, balanced eating, keeping active, smoking, drinking, and how we deal with life stresses and challenges all affect our health. Our health services, access and use of services that prevent and treat diseases influence health. Stigmatizing substance abuse, which may contribute to a reluctance to seek disease prevention and drug treatment services. And finally, our gender. Men and women suffer from different types of diseases at different ages. And so what are these non-medical psychosocial stressors that I keep talking about? There are several behavior and contextual factors that appear to increase our risk for opioid addiction. Certainly, opioid addiction is not restricted to those of lower income. Further to these determinants of health, there are significant non-medical psychosocial stressors that impact on our health and contribute to any chronic disease, including addiction. Those psychosocial stressors include social disenfranchisement, cultural loss, insurmountable tasks, erosion of self-esteem, loss of mastery and control, and a lack of meaningful employment. Typically, the more people that are experiencing these stressors, the less their ability to mitigate this stress. The more access to resources you have, the more your ability to cope with stress. Those with money might mitigate stress by going on a holiday. But if you don't have money, you can't take that holiday, and the stressors continue to mount. Those psychosocial stressors also show up in the higher income brackets as well. It's an incredible stressor when you are living beyond your means, trying to keep up with the Joneses or a social class. Ask anyone who does not have meaningful employment what the impact that is on their everyday stress. All of these impact on health and contribute to health disparities. Opioids can be a psychic armor, a powerful means of coping, an emotional crutch, an unparalleled ability to alleviate stress. To show this in a diagram, when the non-medical psychosocial determinants of health are not met, it results in stress. Socio-historical factors increase risk, and this stress can result in risky behavioral responses. These behavioral responses are also influenced by environments in which people live, work, and play. And so how do we prevent risky behavioral responses that are the result of a stressful life or a loss of power? How do you do this when our healthcare system is largely focused on curative health? A strategy to address addiction is too late. To prevent disease, it's necessary to address these psychosocial stressors. It's not just about putting the fence up. The approach needs to be multi-pronged and holistic. There needs to be considerations for socio-cultural norms. What may be helpful for one group may not be working for another group. So there's a real need to tailor and understand the importance of family, ancestors, wider community, and the land. For it's these non-medical primary preventative health activities that are going to improve health outcomes in the long run. David Campbell is one of my colleagues at the Centre for Remote Health in Australia. He's a brilliant progressive behavioral economist with a specialty in these non-medical causative factors that affect chronic disease. He's used the Aboriginal experience as a case study for some of his work, and we've had some extensive discussions about this topic. I ask him, I say, so David, what should the ratio of preventative to curative funding be? In my mind, if there was some kind of economic criteria for distributing the funding between preventative and curative health, then perhaps there might be some slight hope of having less political influence as the driver. David suggests that we think of it in a different way. It shouldn't be competitive. It's not that you take money from secondary or tertiary healthcare and put it in primary prevention. Initially, there will need to be more money spent on primary prevention, but in the long term, there will be less money needed for curative health. As well, investing now in primary prevention means people will live longer. They will be functioning and contributing and increasing the tax base. It's a long-term investment. Change will take a long time, but it makes economic sense. How do we get our society, our policymakers, and our politicians to buy in? So what's holding us back? Oligopoly. That's a big word for me, new one. It means a state of limited competition in which a market is shared by a small number of producers or sellers. There is a social preference for curative health. There is a certainty in receiving treatment for a specific condition rather than the uncertainty of population-based preventative strategies. There's a competitiveness in our society for bigger and better, newer and more inexpensive curative technologies. There's a powerful oligopoly that uses political influence. We certainly need medical care and expertise in treating addiction, don't get me wrong. But there are times when the medical model has a disproportionate say in the way health services are delivered and funded. We need to shift the power to include more primary prevention if we are to see progress in our health system. Developing partnerships outside the health system will help in addressing the determinants of health. We have fairly restrictive roles. We need to broaden those roles. We need to be infusing health into our communities. As healthcare providers, we need to place as much value in the role of the nurse sitting on a committee as we do the nurse in emergency. The ultimate goal of primary health care is better health for all, and the World Health Organization has identified the 5 key elements to achieving that goal. Interestingly, tertiary prevention can actually be seen as a failure of our primary prevention healthcare system. There's been call after call to refocus policy and funding strategies. It's a call to focus on social determinants of health, to do more health promotion, a call to ensure primary health care funding is based on the demonstration and evidence of positive health outcomes, a call to establish partnerships between communities and healthcare providers, a call to ensure people individually and collectively participate in the planning and implementation of health policy, a call for health to have a seat at the table when it comes to housing, education, employment, water resources, and environment. Improving health can only be achieved by placing health in its social, cultural, political, economic, and environmental context. Health is not just the physical well-being of the individual, but the social, emotional, and cultural well-being of the whole community, in which each individual is able to achieve their full potential as a human being. Are you a nurse, doctor, or other healthcare provider who works in emergency? How can you shift your role so that you are linked more with the community? How can you do something about the patterns that you see over and over and over again? How many people have you had in your emergency room related to opioid addiction? What do you do about it on a systemic level? So glad you are here today. And how do we get the acute care system to be thinking more about primary health care? We need to be thinking beyond the restrictions of our current roles. We need to place value on these non-clinical aspects of our roles. When was the last time you had a community collectively participating in the creation of a health policy? Does health have a seat at the table for community infrastructure design at the City of Whitehorse? Is there a health representative in economic development? We need to be infusing health more broadly. Is there someone from health working with the mining industry? What is local business role, and where is, our role in this business role in preventing addiction? How does a business support an employee who has experienced a trauma or a significant life event? The healthcare provider role in these groups is not a medical role, but one that brings your expertise in understanding how the decision-making that is occurring in other areas impacts on health. Sitting on a committee with a view of ensuring supportive social structures and social inclusion will have important impacts on health outcomes. To challenge you a bit further, how many of us give value to such a role or could actually visualize these as medical roles? Primary health care, when done well, is a cost-effective means of improving health outcomes. Sometimes I wonder if this is how we lost the focus and what is needed to shift priorities in the health system. The acute care system is full of busyness, fast thinking, and speed. We need to take a profound pause. The opioid crisis in our health system is our health system crying for help. We need to take this time for a profound pause so that we can come out with strategic and innovative transformation. There is not a doubt about it, as every person in this room has been profoundly affected by opioids. We certainly can't dispense with the ambulance now. But, as an old sage remarked in 1895, it's a marvel to me that people give far more attention to repairing results than to stopping the cause. Thank you.